as we go a little bit deeper down, so you think about it, the tib post starts later. So my insertion point is further down than when I just do the gastrocnemius. So I go down to tib post, I pull out, and I aim more proximal to get to the gastroc. So the tib post is very deep on this area. So we're stimulating at the bottom of the screen, and our needle is going down here to get to the tib post. Then we can pull back for soleus and gastrocnemius. With my colleague Josh Vova, east of you in Atlanta, we've done a lot of work on this area. So this is what it looks like, gastrocnemius soleus tib post. Very easy to see. And here would be an example, and this is a good idea when I talk about tenting of the fascia. You see how my needle is sort of pushing the fascia along? So some of these muscles are so fibrotic that you don't get a stim until you break through the fascia. So in this case, we did go through approach. So there you see the gastrocnemius. And then you're going to go deeper from the same view into the soleus. And you see the stimulation happening. And then, of course, we'll go deeper into the tib post. Now, important thing about the tib post is the sensory branch of the tibialis posterior going through is there. So if you start stimulating or freezing and they say, I'm getting tingling in my feet, you need to stop and reposition and avoid that. So you can see the Neapolitan approach of the three muscles. In contrast, this is a 6-year-old child. So if we look at the 6-year-old child, you can see the gastrocnemius and soleus here in tib post. Now, arrangement-wise, by the fibula, you're going to have the flexor hallucis longus behind, and by the tibia, you're going to have the FDL. So if we look at that arrangement as well, I'm going into the tib post, but right against the fibula is actually the FHL. On the other side, it's the FDL.
Heels are on the ground.
So everyone wants flat feet, and even if we can attain it, doesn't mean they can sustain it without a surgery such as a splat procedure or
and
a
now do that
lengthening.
on that side.
Oh, look at that.
What's different?
That moves.
What normally happens?
It doesn't.
So this is an adult with CP, and she actually was referred to me for back pain because no one really managed her CP. And after we did the leg, she's like, "Oh, do you think I could start running?" I said, "Sure, why not?"
TBI? Long time ago, 24 years ago?
23 years away.
So he's got sustained clonus. And his maximum range when we stop that, it's even hard to find.
Yeah.
Right, good. So, he gets to neutral.
Yeah.
But here is
Yeah.
really good. So look at that, he's got amazing flexible feet. So, yeah, can't even tell.
So he
So if
has
we don't do
sustained
solus,
clonus.
we won't stop the clonus. But there's really, like Andrew said, is there tib post? We don't know because there's so much shaking.
It's right there.
And you had a hip replacement.
So
on
you
the
could
side.
see just how full reduction of the spasticity after the procedure. And, many of these patients say they don't feel weak when we knock out the nerve to spasticity. 1 year later, he's just got a little bit of clonus, but the range is great. So I think we decided to repeat him about 15 months when the clonus became a bit of a bother. And here is a 10-year-old boy who has, chronically contracted ankle, gastric soleus. And we also did his hamstring, so you can see his maximum range of motion, and boom, good ankle dorsiflexion after the procedure. So very nice result for him. And that's an instant result. Now he's 10, we did him under sedation. There are some kids who can tolerate it without sedation, but the vast majority we will not. And this was him the day after the treatment. He does play sports, but he had a significant heel off the ground when he was running before. And this was a big day, the day after, because he could go down the stairs one at a time.
Just keep walking to the door.
So this is a more complicated pattern of a woman who has inversion and a hitchhiker toe.
So maybe there's tib ant there, right? Just keep walking
So we
to
see
the
the
door
tib ant
and
pulling
turn around
under.
and come back.
But we're not sure if we need to do tib ant. Is it just fighting
So
it?
maybe there's tib ant there, right?
And we got a great result with her by doing gastrocnemius soleus tib post and then we do tib ant if it's still
Oh, here
pulling.
already.
This gentleman was
Walk
more
that way.
complicated. He has significant
So he's got
inversion
that
of his foot,
significant
and in
hyperextension
this
as well.
case, we found it was tib ant he needed plus EHL, and it wasn't until we got the EHL that the leg
Walk that way.
actually went down fully.
So he's got that significant hyperextension as well.
So here he is learning to walk with a totally different foot.
And walk that way.
And just go.
And with his brace, he's
Don't
doing
show
great.
off, man.
And there's that associated reaction.
Excellent.
His arm was so stiff, we got a good result, but when he walks, they still flex. So you got to train that. We spent a lot of time talking about FHL and EHL, and the simplest way to see it is it's on either side of the fibula. So your anterior part is your EHL and your posterior is FHL. This is actually me doing a rhythm. And you can see it here, and I would do this for toxin or nerve block. Here's our cryo going in. The one caveat is if they are on a blood thinner like apixaban, this is a deep compartment, so you have to be very, very careful to avoid a blood vessel, or maybe even get them to stop the apixaban the day before because you don't want them to have a bleed. So for the spastic toe claw, we have a protocol that we use. And so you can see here, the classic way that you would inject toxin would be that triangle of the FDL. So can do the FDL from that position. And sometimes what I'll actually do is get them lying on their side, on the affected side, so that their leg is facing the sky. So, almost like I'll show you in this position, so that I can come in this way into the FDL at a nice angle, because I like to keep my probe at that 45 degrees. For the FHL, I basically do the opposite. I get them lying inverted in this way, and go posteriorly to their leg from the outside and get their FHL. So we kind of turn the patient to get to the position that we want. This is a nice example of a spastic toe claw. So this was
What's
FHL
different?
and FDL and nothing else.
This is incredible.
Keep going the other way. Look how fast. Don't worry about holding it. You were walking so fast.
I haven't walked this fast in years.
So quite happy. So we published this case report of an MS patient with burning feet and toe claw. And so this is right from the pain literature doing a superficial fibular nerve or perineal, depending on how old you are. And you basically just go under the skin and we do above and below the lesion, just making sure it's a very thin area. You don't want any frostbite, following by the FDL for her toe claw. And this was a really great procedure for her. We did both of these areas, FDL and the superficial fibular, and we published this as the case report. And you can see, the FDL going up and down. This is actually me showing how I pump that muscle, and this is my resident injecting my FDL with some saline just to show the target in. That he's going to look for a nerve branch. Maybe going a little bit deeper would be better. We can also turn it longitudinal if you're not sure to get those FDL fibers. This is a very blood-rich area, so you often have a blood vessel. This is just an example from another case of how we do it. One of the things that I didn't mention last time is that, cryo is painful. We get a lot of spasm and cramping with the procedure. So we have a virtual reality in the clinic. We can do some nerve stim to bring it down. We have a little cheap Amazon massage gun, which is probably the best thing we have. As soon as the patient starts going, it's really cramping, it's really hurting, we put on the massage gun. And the pain is that cramp fasciculation that they get, and it should stop as soon as the ice ball goes. Occasion will continue on. If it's still cramping and painful, we do a lidocaine rescue. We just inject some lidocaine around the nerve, and that should stop the area. I didn't talk about side effects last time. I can't remember. So this was the side effect paper that we wrote, and the side effect was we did an early review of 3 studies we had, 277 nerves on 113 patients. And what we found is that no one had ever published on motor nerves or mixed motor sensory. And after the procedure is painful and there might be some peri-procedural pain, but in the weeks and days after, 96.75% of nerves didn't have a side effect, which is good. But if they did have pain, it was usually because we did an incomplete motor sensory block. And we now know if they have really bad pain after, it's because we didn't do a complete sensory lesion. And the simplest thing is to complete it. If they get a pain comes on at 1 to 2 weeks after, it's because you froze a little bit of a sensory fiber that was not close to it. So it got a little bit of damage, and like 5 days later, the damage is completed. In that case, usually a bit of a cortisone injection and lidocaine can help. But if it was really bad again, you'd want to cryo it. But I don't want to take away extra sensory. So usually topical Voltaren, topical lidocaine should settle that down. And of course, we're doing up to 20 nerves on a patient. So when I say 96% of nerves, now that we do so many more nerves than we did before, there is a chance more that one of their nerves is painful, but we're getting better and better. One of the other reasons for side effect is, they'll say a week later, the bottom of my foot is killing. And you examine them and